Hi everyone, we are here with Professor Wilde from the University of Amsterdam, which is chair and first author of the recently published consensus document on the role of genetic testing in diagnosis of cardiac diseases. Professor, in the document it is stated to examine specific genes for specific cardiac disease. What is the role of big panels in clinical practice, and how to manage patients with VUS, which are not uncommon findings, especially with big panels?
Yeah. So the reason that we are not favoring the big panels to start with is exactly that the yield of finding a VUS is so high, much higher than finding the causal variant, is that and then when you have these VUSs, you don't know what to do with it. So if the diagnosis is long QT syndrome, if you have a clear clinical diagnosis of long QT syndrome, we think it's wise to start with the 7 or 8 genes that are definitely associated with long QT syndrome. If you don't find it there, you can expand your panel to a few more genes that have moderate evidence for association with the long QT syndrome, and then I would stop. Because finding a VUS in DSP or in DSC, one of these desmosome genes in a real long QT patient, is not going to help you. There is a role, but the role is more in the research setting. So in experienced hands, you can do big panels because you will learn from it, and the additional yield that you have with these big panels can be of interest in the research setting. If you have a good database, if all your patients are well registered, well phenotyped, and then at the point in time you may find an association between something new, but only in that setting. So I would discourage it if you are a private physician or a private cardiologist just by yourself. I would definitely discourage it. But in experienced hands, there's nothing against big panels, but then it is secured what will happen with the VUSs that are found.
Yeah, thank you, Professor. There may have a role in victims of sudden deaths without a clear phenotype, or
yeah, there it's even more difficult, and that relates to the phenotype. So that a sudden cardiac death, or sudden death I should say, without clear cause, is, so to say, a dirty phenotype. It's a definite phenotype because the patient is dead, but you have no clue what the reasons is. And then do genetic testing is most of the time not going to help you. I showed results today that the yield is in the order of let's say between 10 and 15%, and the yield of finding a VUS is more than 40%. And then if that is disclosed to the family will get nervous because something has been found, something that is interpreted as being abnormal. Their brother or their sister or their father died at young age, and once again, if that is not in experienced hands, people will link these things together, and they will become very nervous about this finding. And that can all be prevented by simply not doing it.
Thank you, Professor, for your insights and your time.